Hello, and welcome everybody to the first class in the Truth About Thyroid Cancer seminar series. This is Thyroid Cancer 101. I'm Daria Gerald, and on behalf of ThyCa, the Thyroid Cancer Survivors Association Incorporated, the Light of Light Foundation, and AZI Incorporated, I am so happy to welcome all of you here today. We are very, very lucky to be joined by Dr. Greca. She's an endocrinologist at the University of Colorado Hospitals, and she's going to be leading today's discussion. And today's discussion will cover kind of the basics about thyroid cancer. My role today is simply to kick us off and ask a few questions along the way. Before we get started, I do need to mention some of the guidelines about questions and comments in this class because we have to be mindful of the FDA's rules on communication. So we need to refrain from discussions about or direct or indirect references to any specific therapies or drugs. Additionally, this presentation is intended for US audiences only, and please be aware that it is being recorded. Also, during the course of this session, we will be asking for your optional feedback, and that's going to happen in two ways. The first is that we'll make use of polls, and that is something that will pop up onto your screen, and you can answer those if you want to. Additionally, we'll be asking for a virtual show of hands, and that's using the raise hand feature, typically found down at the bottom of your screen in Zoom. So without further ado, I'd like to pass it over to Dr. Greca to get us started.
Thank you, Daria, for that kind of introduction, and good evening, everyone. So I'm an endocrinologist, and I work at the University of Colorado, and I'm a thyroid cancer specialist. So I'm really exclusively working on thyroid cancer almost every day. As Daria said, I'm not going to be talking about specific cases, and we do encourage you to make an appointment with an endocrinologist if that's the case, if you don't have one. So I'm very excited to give this talk about thyroid cancer. And I'm going to first thank ThyCa and Light of Life for inviting me for this session, two wonderful associations for thyroid cancer survivors and families, and ISA for sponsoring this event. So I'm going to start with this question first. What is thyroid cancer, and what are the various types of thyroid cancer? So let's talk a little bit about the thyroid gland, which is one of our body glands that is sitting on the lower part of the neck, and it has a butterfly shape. And it has two lobes and isthmus, which is the little part on the center that joins both lobes. So we only have one thyroid.
Doctor, can I just jump in before we get too deep
Yes.
into the thyroid itself? I was wondering, maybe we could ask the audience a little bit about why they're here.
Sure.
There should be a prompt for a poll up on your screen where you can choose, and you can check all that apply. You're living with thyroid cancer, or someone you know or care for is living with thyroid cancer, or maybe you're not personally affected and you're just here to learn. If you could do that and give us some answers there, and then Dr. Greca can share with everybody what the results are. I'm sorry, I didn't mean to interrupt.
No, that's perfectly fine.
Do you see the results there?
Okay, so I think most people are living with thyroid cancer, 81%. 6% are living with somebody with thyroid cancer, and then 13% are not personally affected, and they're just here to learn more about the disease. Good, thank you. Okay, so I think I described what the thyroid gland is, the structure is, and it makes thyroid hormone. Thyroid hormone is a metabolic hormone that pretty much regulates every function on our body: the body temperature, the energy, your sleep, your circadian rhythm, your heart rate. So what is the a thyroid cancer? So a lot of people have thyroid nodules, which are growth on the thyroid gland, and some of them are malignant, and that's what's called thyroid cancer. It's essentially a lump on the thyroid gland. So in this country, there were 53,000 estimated new cases of thyroid cancer last year. And in 2017, there was an estimated 860,000 people who were living at the same time with thyroid cancer. So it's the 12th most common cancer, and it accounts for 2.9% of the new cancer cases in the US. More than 70% of the thyroid cancer patients are women. And here we go for the thyroid cancer subtypes. So 90% of people have what we call differentiated thyroid cancer, and we're gonna jump later on the next slide of what are the subtypes of differentiated thyroid cancer. 2 to 3% have what we call medullary thyroid cancer, and then 1% have the most aggressive form, which is called the anaplastic thyroid cancer. So the subtypes of the differentiated thyroid cancer, and the name comes because the thyroid cancer cell, it's very similar to the normal thyroid cell, but it's actually a malignant growth. So 80% have papillary thyroid carcinoma, 10 to 15% have follicular thyroid carcinoma, and then 5% have something that is a little bit less common, which is called Hürthle cell carcinoma. And I think it's very important that you are aware of what type of thyroid cancer you have. Sometimes we ask patients in the office and they're like, I'm not sure, I don't know. It's very important because for communication between your providers, you need to know what type of cancer you had. So understanding your thyroid cancer is critical in determining your treatment plan and setting expectations.
So can I just jump in here, because
of course.
So often we hear thyroid cancer referred to as a good cancer. So using the show of hands feature, how many of you out there in Zoom land have heard thyroid cancer referred to as the good cancer? Oh, and there go the hands. Oh my gosh. I see 40 hands raised there, doctor.
Okay, so 40 people, so more than half heard about this being named as the good cancer. And I think that comes from the, in general, good prognosis that this has, but there are some people that struggle with this condition, this disease, and need a lot of treatment. And we should probably never use that term of the good thyroid cancer or the good cancer. So when adults have a thyroid nodule, almost 90% are benign, but 10% of these nodules could be cancerous. And usually the typical step is an ultrasound and then a FNA, which stands for a fine needle aspiration biopsy, which is done in the office. Usually I do those in the office. I do many of those a week. It's a very simple process, and you get some cells aspirated out of the nodule, and then you look at the microscope, and the pathologist decides or names that cancer if the cells are malignant. In children who present with a lump on their neck, or they have a lump discovered by any imaging study, CT scan, ultrasound, the chances of that being malignant is much higher. It's about 20 to 30%. So we have to be very cautious about that. So what are the main symptoms of thyroid cancer? And I have to say that almost 90% of these lumps are asymptomatic. But the ones that are symptomatic could present with this unexplained chronic cough, persistent hoarseness, or you feel that your voice sounds different than always, difficulty breathing or shortness of breath, difficulty swallowing, or you feel a lump when you have your hand around your neck area or shaving, for example, men. A lump that your physician felt, or yourself, or your mother saw it, or your grandmother, or a swollen gland, which is usually, it's an abnormally large lymph node. So I think we have a question here.
Yeah, what I wanted to ask everybody is, again, using the show of hands, how many of these symptoms sound familiar to you? And, you know, have you personally experienced them, or the people that you're caring for? You know, what sounds familiar to you? Oh, the hands are going up.
Okay, so.
Yeah, I see 33 and climbing, yep.
So again, you know, if you start coughing or you start having trouble swallowing, that doesn't mean that you have thyroid cancer, but it's worth to have your PCP check it and order an ultrasound or feel your neck or whatever that study is indicated at that time. So what are the stages of differentiated thyroid cancer? And remember that DTC stands for differentiated thyroid cancer, and it includes papillary, follicular, and Hurthle cell carcinoma. So on young people, and that's considered patients that are less than 55 years old, there are two stages. Stage 1, which is any tumor that is localized on the thyroid or even in the neck, even could have spread to the lymph nodes on the neck. And stage 2 is the patients with distant metastases. And again, good prognosis on people that are 55 years of age or younger. On older people, there are 4 stages, and we start with stage 1 when the tumor is less than 4 centimeters and it's just confined to the thyroid gland. Stage 2 is any tumor that is over 4 centimeters or any tumor that is smaller than that but has spread to the lymph nodes on the neck already. Or it has spread to a little bit outside the thyroid gland, and that's called extrathyroidal extension. Stage 3, it's any tumor of any size with extension into the subcutaneous tissue, the larynx, the trachea, the esophagus, the recurrent laryngeal nerve, which is the one that gives you, you know, the vocal cord mobility and the voice. And then stage 4 are those tumors that have distant metastasis, and that means outside the neck. So lungs, bones, brain, etc. Medullary thyroid carcinoma, which is that 2 to 3% cases of thyroid cancer, also have 4 stages. And stage 1 is the tumor again inside the thyroid gland. It's a small tumor, less than 2 centimeters. Stage 2 is a tumor over 4 centimeters, but hasn't spread out the thyroid gland. Stage 3, it has spread to the lymph nodes on the neck, regardless of the tumor size. And stage 4 is divided into A, B, and C. And this has to do with what is the invasion. Moderately advanced, has extensively grown outside the thyroid gland and has invaded the lymph nodes. B is, it has invaded the spine, the large blood vessels, if you heard about the carotid and the jugular vein, which are the vessels that bring blood to the brain back and forth. And metastatic is the stage 4C. So what are the stages of the anaplastic thyroid carcinoma, which is that 1% of the thyroid cancers, which is very, very aggressive, inclusive at presentation? It's considered stage 4, and it's, so there's no 1, 2, or 3 for anaplastic. And the stage 4 is divided into A, B, and C. A is when it's in the thyroid, and the tumor could be more than 4 centimeters. B is when it has spread to the lymph nodes on the neck and to some of the, it has invaded the subcutaneous tissue, the vessels, the prevertebral fascia, and 4C, it's metastatic thyroid cancer. So this is very crucial on your journey with thyroid cancer, getting to know the healthcare team that it's gonna follow you with this condition. It's been shown in multiple studies that a team with experience in thyroid cancer management translates into better outcome for patients in every sense. And we're going to go in detail about this. So who are the team members for the thyroid cancer management? And here I'm going to start with the endocrinologist. That's my role. And we take, and we go on the next slides about one in detail, but the next person is the surgeon who's going to do the thyroid cancer surgery, the nuclear medicine specialist, because we have a treatment which is called radioactive iodine that treats patients. Some patients need this after surgery. We have the pathologist, who's the one who's reading your biopsy or your cytology when you had the tumor excised, removed from your neck. And then some other patients need more advanced therapies, which are the radiation oncologist. And then we're not gonna forget about your PCP, your nurse practitioner, the social workers, the psychologists, the psychiatrists, which help us on this journey as well. And I think we have another question here.
Yeah, this is a great time to ask everybody, through a show of hands, how many people see an endocrinologist on a regular basis? Oh, that's adding up quickly. That says something good about your profession, Dr. Greca.
Yeah, so I think, so it's 40 participants. Interesting. I think everybody who has a diagnosis of thyroid cancer should see an endocrinologist at least once. Very small thyroid cancer who have very good prognosis and were removed at the time of surgery could follow up with their PCP. It has to do with the location of the patient if they live in very rural areas. But I think it's very important that you see an endocrinologist who's the person who coordinates the whole care of this. And we're gonna describe who's that person. So we take care of not only thyroid cancer, I think the most prevalent condition of an endocrinologist is diabetes, but some of us just do thyroid conditions and thyroid cancer. So it's important that if you have an endocrinologist, that person has a high volume of patients with thyroid cancer and knows about this condition. If you don't feel that your endocrinologist has a lot of, it's familiar with some of the thyroid cancer, just ask for a referral. They all know who are the big centers for thyroid cancer management, and they're usually pleased with that. I mean, so that also should be coming from the patient as well. So the surgeon is the person who removes the cancerous lobe, which is half of the thyroid. That's called a lobectomy, or the entire thyroid. That's called a total or near total thyroidectomy. And the surgeon would also do removal of some of your lymph nodes if they have thyroid cancer. And it could be the lymph nodes in the central neck, which are those lymph nodes around the thyroid gland, or some lymph nodes on the lateral neck, which are on the sides of your neck and also have a spot of thyroid cancer. Nuclear medicine specialist, I mentioned before that thyroid cancer responds to this radioactive iodine therapy. And some patients, after a total thyroidectomy, you need to have the whole thyroid gland removed to receive radioactive iodine. Some patients would qualify for this additional therapy. And the intention is to kill all the little spots that may have a spot of thyroid cancer that we are not seeing after surgery. They are called microscopic spots. I'm not sure if we're gonna answer questions at the end. There's some people raising hands. Do you wanna? Should I keep going? Okay.
Yeah, you know, the chat and everything is disabled for this, so I would say just keep going.
Okay, that sounds good. I'll keep going, and then we will see if we could answer at the end. So the pathologies, again, I think the main thing is the person who identifies your cancer and says, yes, this is a malignant condition. I also want to say that you could ask for a second opinion as a pathologist, and you want to say, I want to have my slides reviewed at another center, and that's perfectly fine. There's multiple centers in the US who review your slides for a fee, and I think it's depending on insurance or you know, that part, of course, I don't exactly know, but you could have your slides reviewed if you're not sure if this is what's found on your neck. And then again, some patients need the medical oncologist or the radiation oncologist. And I see some patients on a clinic that we have that it's called the multi-D clinic, multidisciplinary clinic. And I work with an oncologist and a radiation oncologist, and we all discuss about these cases that are a little bit more complicated. Those are usually university centers. There are many, again, in this country that could help you with the treatment and management of your thyroid cancer. What are the other healthcare professionals? And again, this is very important that you always have your primary physician involved on this, and then physician assistant, the nurses, the nurse navigators. My nurse navigator is awesome, and she helps me coordinate a lot of things. The lab technicians, the imaging specialist, the social workers, and I think, again, the psychologists, the psychiatrists, the ones who are taking care of our mental health, that's very important. I would also add here the groups that support these, like ThyCa and Light of Life. It's very important that you contact them. They're very supportive. They meet almost once a month on every state, and it's per patient opinion, it's very helpful. So what are the three phases of managing thyroid cancer? First, testing, then we go to treatment, and then the recovery and the monitoring. So I'm gonna go through these, but it doesn't mean that every patient needs all of these tests. So what are the typical tests that everyone with thyroid cancer needs? Is the neck ultrasound, right? Because it's the way we diagnose the thyroid nodule. It's the way we assess the lymph nodes that could be affected for thyroid cancer. So everyone needs a neck ultrasound before going for surgery. Some other patients go to a laryngeal exam just to make sure that the vocal cords are working fine. And that's important for the surgeon who's gonna plan what are they going to do, neck dissections, know beforehand that you have a vocal cord affected on a surgery for thyroid cancer is very, very important. Then the thyroid function lab tests, the two main tests that I order are a TSH and a free T4, and that helps us to supplement the patient with the thyroid hormone after surgery. And we check those at every visit to make sure that we're giving the patient the right dose of the thyroid hormone. Some patients will need a thyroid scan. Some nodules that we're not sure if they're functioning, if they're making too much thyroid hormone, which are called hot nodules, need this test. Usually thyroid cancer or thyroid nodules that need a biopsy are called cold nodules. Some patients need a chest X-ray. Some need a CT of the neck and chest to better assess before going for surgery. Calcitonin testing is one of the tumor markers for medullary thyroid carcinoma. And then the last one is the 5-meter aspiration biopsy, which is clearly on this graph with a little needle that goes into that nodule and aspirates cells to see if these are malignant or benign cells. So now we're gonna talk about treatment. And the treatment of thyroid cancer includes, we have several options now. The first one, it's called active surveillance, and that's offered for very small thyroid cancers that are not invading anything outside the thyroid gland. You need to have a very good team to offer these. This cannot be done on every setting. Not everybody knows how to do active surveillance. So if you decide to do that, just do it on a center where the surgeon, the endocrinologist, the nuclear medicine specialists know what they're doing, and they looked at the images and they tell you if this is dangerous or not. This can all be done at any center. Surgery, which is the options are again lobectomy, which is just the removal of one lobe. And the idea of removing one lobe or half of the thyroid gland is first, maybe some patients won't need any thyroid hormone after that because the other lobe is making sufficient amounts of thyroid hormone. Some patients need a near total or total thyroidectomy, which is the removal of the whole thyroid gland. And some patients need a total thyroidectomy and removal of lymph nodes next to the thyroid gland. The other treatment in thyroid cancer is called radioactive iodine treatment. And again, not every patient would need that. Thyroid hormone replacement therapy, I think 50% would require some sort of thyroid hormone supplementation. For higher risk cases and tumors that are more invasive, we have lateral neck dissection, which is just the removal of the lymph nodes on the lateral neck. External beam radiation therapy, which is usually given after the removal of the gland and treatment with radioactive iodine. And then some other cases need something that's called chemotherapy, systemic therapy. There's the whole new group of drugs that this is very exciting in thyroid cancer. There's so many options now to provide for patients with thyroid cancer that have more advanced disease. So going into recovery and monitoring, and this is very important to understand that every patient needs to understand that the monitoring of thyroid cancer is lifelong. It could be every few years, it could be every few months, every patient is different, every case is different, but this is a lifelong monitoring. So it has different components. So one is the hormone replacement therapy. And for that, we check that TSH, and I also check a free T4, which are the hormones who tell me what is the function and level of the thyroid gland. You have to take it exactly as prescribed. If you don't take your thyroid hormone as prescribed, then the levels are never right. It's people have a lot of trouble with this. And then we monitor the levels at every visit. You know, if it's every 6 months, if it's every year, if it's every 18 months, depending on the case and the patient and the physician. So for the differentiated thyroid carcinoma, remember it's papillary, follicular, and cartil cell, we check a TSH, and we also check a thyroglobulin, which we call that a tumor marker. And the reason for that is because when we don't have a thyroid gland anymore, we should see a thyroglobulin level very, very low, right? Or undetectable. So we check that level at every visit. Some patients have anti-thyroglobulin antibodies. So this is part of having an autoimmune condition called Hashimoto's disease. And about 15% of patients with thyroid cancer had the antibodies. And that doesn't give you a worse prognosis. It's just a test that interferes with the measurement of the thyroglobulin. So on those patients, we try different assays. It's hard to follow that marker. So we have to know that. So we check that at every visit as well. For people with the medullary thyroid carcinoma, the two main markers are calcitonin and CEA, or carcinoembryonic antigen, and we check those at every visit as well. And then what do we do to see if the cancer is back, is not back, the patient is in remission? The main one that I do in the office, it's a neck ultrasound. And initially we do one every 6 months, and then we start doing one every year. And then when patients are in remission, then we do one every 18 months or every 2 to 3 years. Some other patients need a computed tomography, a neck CT, or a chest CT. Some patients that have more aggressive disease need a PET scan or a MRI, and those are more sophisticated tests that give us a more idea if the thyroid cancer is somewhere else that we're not seeing. Okay, I think we have a question here.
Yeah, so there's often challenges that are faced during this process. And we wanted to use a show of hands just to ask, have you faced challenges? And when I say challenges, I mean, symptoms like lack of energy, weight fluctuations, trouble sleeping, hair loss, temperature sensitivity, or even anxieties. Do you have any fears of a recurrence or constant monitoring of the TSH, spending a lot of time going to doctors, surgery, fear of surgery, just kind of this big umbrella of challenges during the recovery process. And already we've got a lot of hands up. The other thing I'll mention, I know some people were raising hands to try and ask questions, and I did want to apologize that we really can't take live questions during this particular session. We will be having some additional classes in the future, and we're going to work on that and see how we could incorporate questions and answers from the audience. But in the meantime, we do apologize, but we do suggest that, ask your physician, go to your personal doctor, or check out the great resources at Light of Life and ThyCa.
Good. So 37 participants had some of the symptoms, and this is very common. You just have to work very, very closely with your endocrinologist to try and find the right dose of your thyroid hormone. If you're anxious about this diagnosis, work with your therapist and your endocrinologist to see what are your questions, what are your concerns, why is this concerning for you? Is this something you could do differently? Would you go for a second opinion? So those are very important things. And there are resources, and you should never be, having anxiety for years or years about this. Seek another opinion if that's needed. So here's the last slide, and these are wonderful websites and resources for patients or families that have a family member with thyroid cancer. I hear this in the office all the time. It's very important that you make some contact with the people with the same condition out in the community. So I'm going to end my talk here, and I'm going to thank you, ThyCa and Light of Life, for this wonderful opportunity to talk about thyroid cancer. And I'm going to thank you, ISI, for sponsoring this event. And again, I wish we could answer all the questions that are coming out there, but I'm sure we're going to have more opportunities for those with questions.
Well, Dr. Greca, thank you so much for this wonderful presentation, and thank you everybody out there in Zoom land for joining us. If you've enjoyed this session, please stay tuned for some upcoming classes. There'll be a cooking class. Be sure and mark your calendar for March 24th. And there'll be another class called Finding the Right Care for Your Needs. So thank you again, everybody, for joining, and we'll see you out there on the internet someplace, I'm sure.